Hello everybody, I'm Conrad Fisher. I'm the Associate Chief of Medicine for Education at SUNY Downstate School of Medicine in Brooklyn. I'm so happy to have you here with me again. I welcome you to cardiology and I wish you great success in your step 2. Remember that the basic format of all questions on USMLE starts out where the question writer says, I'm going to give you some history, I'm going to give you some physical examination, I'm going to give you some labs, or maybe not some labs, and from this position I'm going to ask you a couple of basic questions. I'm going to ask you, which of the following is the most likely diagnosis? What is the best initial diagnostic test? What is the most accurate diagnostic test? What is the best initial diagnostic test? What is the most accurate diagnostic test? What is the best initial therapy? Now, what we're going to do is we are going to learn how to think like a question writer. So that means from now on, you're going to think with these questions in your mind. What's the most likely diagnosis? What's the best initial test? What's the most accurate test? What's the best initial therapy? And we're going to fit all the information in the world into your brain in this format. Now, the most common root question is, which of the following is the next best step in the management of this patient? Now, when it says the next best step in the management of this patient, that could be either a test or a treatment. A test or a treatment. Did you know that the most important thing that you come to learn in USMLE preparation is the order in which to do things? I have heard about the tests and the treatments, but what is the order in which to do things? That's the main thing that we come to learn here now. Now, when you're applying for your EROS application, applying for your residency, your whole life is going to get reduced down to about 3 simple facts. What medical school did you go to? What are the scores? If you're a U.S. graduate, what does your dean's letter and your transcript show? And if you're an international graduate, what's your visa? All the other things don't get you that interview. Personal statements, letters of recommendation, pictures, no. Schools, scores, transcript. Schools, scores, dean's letter, or visa. So that means thinking like this is the direct effect on how many interviews you're going to get. So therefore, USMLE preparation, welcome to cardiology, study with the questions in your mind. What's the best initial test? What's the most accurate test? What's the best initial therapy? What's the next best step in the management of this patient? What's the next best step What is the next best step in the management of this patient? Let's look at some cardiology. Well, let's take a look at some of the aspects of chest pain here. Now, the first thing to do is to take a look at a person who's got some pain. Let's see. We have a 48-year-old woman who comes to the office, and this 48-year-old woman comes to the office, and she's got off and on again chest pain for the last few weeks. Sometimes it's with exertion, sometimes it's not with exertion. Sometimes it's with exertion, and sometimes it's not with exertion. So let's look at the qualities of these pain. Now the thing is that this person's pain, let's look here. He could be benign, could be life-threatening. Well, that's not a very specific statement, can't help us. The question is, how do we determine whether it's life-threatening or not? Well, the thing is, what is the most common common reason to have chest pain when you have a woman with no past medical history? What is the most common risk factor for coronary artery disease? Hypertension. Which of the following is the single worst risk factor? Diabetes. Correcting which of the following results in the greatest immediate improvement? Stopping smoking. Stopping smoking. She doesn't have diabetes, doesn't have hypertension, doesn't have hyperlipidemia. And remember, for it to count as a family history, mom and dad have to have their coronary disease young. Dad under 55, mom under 65, dad under 55, and mom under 65. Young has to be in their 50s and early 60s. She has no past medical history. Now you see this slide here where it says, well, exclude the most serious thing first? Well, there's 2 types of questions. The first question is, you have a 48-year-old woman with no past medical history who's got off and on substernal chest pain for the last couple of weeks, with exertion, not with exertion. What is the most likely etiology if somebody's got discomfort there as a woman? She's not young, but then again, she's not old either. During 40 years of the Framingham study in Massachusetts, in 40 years they didn't have a single myocardial infarction in a menstruating female. Menstruating female. The menstruation is like perfume that lasts for 10 years. Perfumes those coronaries, keeps them fresh. Not a single myocardial infarction in a menstruating woman. So therefore, when you have this woman here with off and on pain and no risk factors, the likelihood of this being ischemic pain statistically is remotely small. So we have two questions. What is the most likely diagnosis? What is the most likely diagnosis? Substernal chest pain, off and on, atypical. Throw in a little nausea, a little GI complaint. Reflux. Reflux, reflux, reflux. Well, the most likely diagnosis may be reflux, but the best initial step is still an EKG. The best initial test is still an EKG. Now, the history of the chest pain is much more important than the physical. History is much more important. In other words, if you tell me that this is, whoa my gosh, look at this 75-year-old guy who's got exertional chest pain. Exertion plus pain, chest pain, I don't care what he's got physical exam findings. He's got ischemic disease. He's going to die of a heart attack. Old guy with exertional chest pain, ischemia. Physical examination doesn't show that much on a person with a myocardial infarction. What is the most common exam to be found? Not the most common abnormality, the most common examination to be found. Normal. Did you know that most people having a heart attack, a myocardial infarction? Do you know most of them have a normal physical? Most of them have a normal physical. You could have RALS if you have LV dysfunction. You could have JVD if you have left ventricular dysfunction. You could have an S3 or an S4, LV dysfunction, ischemia. But the most common is normal. What could you find? It's one thing. What's the most common is normal. Let's see. The first thing in the history is what is the duration of pain. If the pain lasts for a second, a needle for a second, not ischemia. A second of pain, 2 seconds of pain is not ischemia. Ischemic pain doesn't last for a second. On the other hand, ischemic pain also doesn't last for hours and hours and hours either. Ischemic pain is 10 minutes, 20 minutes, 30 minutes. If it's a second or if it's hours and days, it's not ischemic pain. The quality. Let's see. First of all, duration, not ischemic, seconds or days. The quality, ischemic pain. The ischemic pain is dull, sore, squeezing. In other words, ischemic pain is like you going to the gym. If you'd ever get to the gym, lifting weights, pumping, and ooh, I'm sore. That hurts. It's sore like a muscle. Ischemic pain, ow, ooh, who hit me? It was me. Ooh, sore. That's ischemic pain. It's a muscle that's sore. Damn, that hurts. Because the muscle, it's ischemic. Sharp, bing, no. Knife, bing, knife-like. Point-like, knife-like. No. Not ischemic. Okay, dull, sore. If they say point-like, if you say to the patient, can you point with your finger exactly on the one point where the pain is, and the guy goes, yeah, it's exactly there. Pointing with a finger, 95% of the time it's not ischemic. Ischemic pain can't be localized to one itty-bitty point. It's sore, it's substernal. Location. Did you know that 95% of ischemic pain is substernal in location? Right-sided pain, not ischemic 95% of the time. Left-sided pain, not ischemic either. Ischemic pain is there in the center. Right-sided pain for sure is not ischemic. Left-sided mostly is not ischemic. Guy says it hurts me there, it's not ischemic 90% of the time. Not ischemic 90% of the time. Ischemic pain lasts for 10, 20, 30 minutes. Ischemic pain is sore or dull or squeezing. Ischemic pain is substernal. Ischemic pain can go to the neck, but the absence of radiation means nothing. Ischemic pain can go to the neck, into the arm, to the neck, into the arm, neck, into the arm, neck, into the arm. Frequency. Ischemic pain can come with exertion, every once in a while with exertion. So alleviating factors means this. Exertional, relieved by rest. That is the definition of angina. Angina comes from the Latin word angere, to strangle. To strangle. My left ventricle is being strangled. Left ventricle is being strangled. So therefore, left ventricle is being strangled, and what ends up happening is that when you have ischemic pain is relieved by rest. relieved by rest. So chest pain that is on exertion, relieved by rest, is the very definition of angina. Now, a person who has associated symptoms, this is the weakest one. It belongs down at the end. See, it's at the bottom there? That associated symptoms is the weakest one. Why? Anything can make you short of breath. Anything can make you sweaty. Anything can make you short of breath and give you a sense of impending doom. They all can make you short of breath and give you a sense of impending doom, or make you sweaty or short of breath. That doesn't help very much. Now, remember here that angina pain is squeezing, tight, heavy, pressure, sore. These are very good words. These are very good words to remember. I mean, they're very bad words to have, but they're very good words to remember. These are very good. Hey, how does it feel? What does it feel like? Can you compare it? Shall I compare thee to a summer's day? Oh, no, I will compare thee to an elephant sitting on my chest. Shall I compare thee to an elephant sitting on your chest? Do you feel like there's a belt around my chest? Now, you have to be careful about what people are saying, because to see what they're really saying. I saw a guy the other day in the emergency room, and the guy goes, yeah, doc, I'm having terrible chest pain. It feels just like a knife stuck in my chest. And all the medical students came by and they said, you know what, Dr. Fisher, this man's chest pain can't be cardiac in nature, because you told us that knife-like, it cannot be cardiac. I said, you know what, this guy is an exception. I think this guy actually does have a cardiac problem. Dr. Fisher, you said if it's point like a knife, that it's not cardiac. But he's a little bit of an exception, is an exception. Well, what do you mean? Well, if you look at the guy, you'll actually notice that there is a knife stuck in his chest. So it's in his heart. So when the guy says, I have pain that's like a knife in my chest, you should make sure, in fact, that there is no knife in his chest. Other than that, knife-like, not ischemic in nature, tight, heavy, pressure, sore, dull. Tight, heavy, pressure, sore, dull. Squeezing. All evil, all evil. Now, the inferior wall myocardial infarction. The inferior wall infarction, the heart is pressing on the diaphragm. In other words, if this is the chest, and this is the heart inside the chest, the inferior wall is in fact on top of the diaphragm. So the inferior wall is, in fact, on top of that diaphragm. So when the inferior wall is on top of that diaphragm, it ends up causing irritation that can cause diarrhea. It can cause bradycardia. Why? Because there's a vaguely mediated reflex. It irritates the diaphragm, it runs up in the vagus, and it causes a slowing of the heart rate. Hypotension, sweaty, shaky, bradycardia. In the past, that used to have a proper name to it. It was called a Jarisch-Bezold reflex. The Jarisch-Bezold reflex is a term applied to the inferior wall inflaming the pericardium, causing you to have vagal tone. The vagus dilates blood vessels. The vagus slows the heart rate. The vagus, because the dilated blood vessels and slowed heart rate, causes lightheadedness. That's inferior wall irritating my diaphragm. Remember, ischemic pain is not sharp or knife-like. And the other thing is, you see this reproduced on palpation? Ischemic pain does not associated with tenderness. If there's tenderness, not ischemic. If it changes with bodily position, it's not ischemic. If it changes with respiration, not ischemic. Ischemic pain is not positional, pleuritic, or tender. Positional, pleuritic, or tender. Ischemic pain is not positional, pleuritic, or tender. It's not positional, pleuritic, or tender. And it's not reproduced on palpation. Now, the pain generally lasts, if it's ischemic, for 20 or 30 minutes. But this thing, look at this. It says relieved by nitroglycerin. Relieved by nitroglycerin. Spasm is relieved by nitroglycerin. That is why here, spasm relieved by nitroglycerin, reflux worsened by nitroglycerin. That's because it opens up the sphincter and more acid comes out. This is why this response to therapy is a very poor way of making a diagnosis. The response to therapy is a very poor way to make a diagnosis. We're going to have to send you to a 12-step group. Hello, my name is Conrad. I admit I am powerless to seeing a response to specific therapy. Came to believe a power greater than myself could save me from diagnosing things with a response to specific therapy. We're going to have to send you to a 12-step group for a response to specific therapy. Okay? You can't use the response to specific therapy to making a diagnosis. There's about 3 exceptions. Opiates and Narcan. Diagnostic and therapeutic. Opiates and Narcan. Esophageal candidiasis and fluconazole. Esophageal candidiasis and fluconazole. Esophageal candidiasis, fluconazole. You can use the response to therapy. And CNS toxo. Narcan, naloxone and opiates, toxomeds, and fluconazole for esophageal candidiasis. Other than that, you will not use the response to specific therapy to make a diagnosis. Now, looking at the physical, what we find out is, you see this sweating and shortness of breath? This is unfortunately completely non-specific. Anything can make you sweat and have shortness of breath. It's too non-specific to be useful. It's evil, but it's too non-specific to be useful to say you're short of breath and you're tachycardic. Now, the thing that would be useful in the physical exam, would be useful in the physical exam is the fact that if you have a difference in blood pressure between your arms, that is indicative of aortic dissection, and that is useful. Now, remember that palpating the pain, the chest pain, means not ischemic in nature. Now, the murmurs and auscultation. Remember that the most common physical finding of the heart in a myocardial infarction, the most common physical finding of a myocardial infarction, the most common physical